Okay, I would like to welcome everybody in this presentation of hands-on seminars. We have a lot of people attending today. We have people from Brazil, we have people from Portugal, and people from the United States who are part of today's presentation. So on behalf of Hands-on Seminars, I would like to welcome you all in this presentation. Many of you have taken similar presentations in the past. This way I will try to keep it simple and also provide you with some new information for those of you who have taken in the past some of our seminars. We have a tremendous demand for a lot of people who wanted to take this, who wanted to attend today's webinar. And from what I'm getting the information that the webinar is right now full, which means that people who are trying to get into the line, they are not able to. However, today's presentation will be recorded, and we will be able to provide to these people the ability to view the presentation. So very quickly, I would like to say that the purpose of hands-on seminars is to provide continuing education in the area of manual therapy at an affordable cost to physical therapists around the world. And you can take courses with hands-on seminars either to obtain CEUs or to be part of our Mastery Certification of Manual Therapy program that we offer it around the world, or to take one of our DPT programs, the Doctorate in Physical Therapy programs, and we offer many courses throughout the year around the world. We have small groups because we believe that practice is very important, and of course we do as much as possible multimedia presentations, personalized attention, and 90% lab sessions is extremely important component of hands-on seminars to provide the information to the participants. Practice is the key to success. That's why we make sure that you master all of the techniques that you learn during our seminar. Very quickly, I would like to mention that our MCMT program, it happens throughout the year. You can register throughout the year in our MCMT program, and for specific information for the program, you can refer either to our website or you can refer to our coordinator, seminar coordinator at 888-767-5003 is her phone number. But there are many benefits to the MCMT. You demonstrate clinical competency in the area of manual therapy. You can add the MCMT title next to your name. You can display your MCMT certificate, of course, and you can earn a listing in the Hands-on Seminars referral website. If you are a company, we will list you in the Gold Partner section of the Hands-on Seminars website if you make a commitment to have all of your therapists to become certified in manual therapy. And in many occasions, you may be able to negotiate either higher salaries or higher reimbursement because you apply an effective, efficient, evidence-based technique, such as the techniques that you learn via the Hands-on Seminars workshops. Now, in order to become certified in manual therapy, you need to complete all of these 5 courses, PT1, 2, 3, 4, and 5, and then to complete the final course, the certification course, and to do specific assignments at the end of every one of these courses, and to take at the end an exam, practicum and written exam at the during the MCMT course. But at this point, I would like to initiate today's topic. I want to talk to you today on the area of myofascial trigger point therapy. Many of you have been exposed to our seminars. You have heard different information about myofascial trigger point therapy. But today, I would like to pinpoint a few things that you may have not heard in the past. Before I mention those things, though, very quickly, I will refer again to a classic very, very typical scenario of a patient that we see time and time again, of a 35-year-old male, frequent computer user, everybody is a computer user these days, who happens to have pain around the eyes, earache, blurred vision, and tinnitus, noise in the ear. And obviously, if a patient with these symptoms go to a physician, the physician will have to come up with a diagnosis. And what would be the diagnosis? Many physicians will call that a migraine headache. Some others, especially if the patient is a female patient, may consider it a hormonal imbalance. I remind to all of you that especially females around the area around the time of menopause, as well as in puberty, many hormones, especially estrogen, may cause migraine headaches, in which case it may be confused for a hormonal imbalance. Also, facial atypical neuralgia. Obviously, in medicine, when we have pain in the face, without being able to define it in specific terms, we call that a atypical neuralgia, facial atypical neuralgia. Is it a tumor, though? Is it stress? It can be all of these possible diagnoses in a case that someone complains of pain in the front of the head, in the back of the head, pain around and inside the ear, tinnitus, and pain around the eye. And depending on the physician may decide to do different types of interventions. Some physicians, they may just give to the patient drugs and ask the patient to wait, or some other physician may ask the patient to do a lab workup. For example, if we're talking about a hormonal imbalance, in that case, laboratory testing would be very important. In some cases, brain MRI, because somebody may be wondering if the patient is suffering from a brain tumor or even an acoustic neuroma, a schwannoma, because as I mentioned previously, this patient is feeling noise in the ear. And in many cases that we are dealing with schwannomas, with acoustic neuromas, noise in the ear is one of the major characteristics. Some other physician may refer the patient for somatosensory evoked potentials, for a Doppler test, or even for the patient to see a psychiatrist. So different physicians will come up with different diagnostic testing and different possible treatments. But what if, about everything I'm talking about right now, a specific muscle is responsible for this condition? And I'm talking specifically about the sternocleidomastoid muscle. What if the sternocleidomastoid is responsible for this condition, and what if a specific clinical examination alone can identify the problem? And you know very well that I'm talking specifically about the presence of myofascial trigger points inside the sternocleidomastoid muscle. Now, real quickly again, what is a myofascial trigger point? We define a myofascial trigger point as a highly localized, hyper-irritable spot in a palpable taut band of a skeletal muscle. So we have a skeletal muscle and a highly localized, hyper-irritable spot within that muscle is defined as a myofascial trigger point. But now, those of you who have especially attended our seminars, we are talking specifically and teaching you on how to precisely apply the myofascial trigger point therapy technique. My friends, one of the challenges that we will all have as we move forward to the new healthcare system, with a healthcare reform that is taking place now in the United States, and by that matter, it may influence the entire world, is the fact that therapies, interventions, medical interventions, and therapeutic interventions, in order to be able to survive in a healthcare reform environment, such therapeutic interventions must have two characteristics. They must be effective and they must be efficient. So effectiveness and efficiency are not the same thing. They are very, very different things. You may have a specific treatment that it may be very, very effective. You can have tremendous effectiveness in the application of a treatment. So here on the very top of this curve, you're going to have an effective treatment. And you may have another treatment. That other treatment can be very efficient or not efficient. So you may have another curve here that will describe in some form the degree of efficiency of a treatment. So you may have then a treatment that can be effective, a treatment that can be efficient. Those treatments that happen to be right up here at the top of this curve, that happen to be both effective and efficient, those are the treatments that survive in the new healthcare environment. Because not only you must be able to deliver precisely an effective therapeutic outcome to a patient, but that therapeutic outcome must be delivered in efficient means. Let's take, for example, you are able to provide a specific treatment to a patient and obtain a specific outcome in an hour and a half. And you apply a different type of treatment. With the different type of treatment, you are able to produce exactly the same therapeutic outcome in only half hour, in a third of the time that you applied the first treatment. So what happened? Both of these treatments are equally effective because both of these treatments were able to produce the same therapeutic outcome, but only the treatment that was able to produce the same therapeutic outcome at a lesser time, with a lesser cost perhaps, was more efficient. So we have to find the treatments that they produce not only effectiveness but also efficiency. Now, myofascial trigger point therapy, it can be a very effective, as many of you know, treatment, but also can be extremely efficient. We apply myofascial trigger point therapy in a therapeutic session for about 10 to 15 minutes at the most. And the patient then may receive, of course, additional treatments, such as you may prepare the area, as I have mentioned to you in the past, with hot packs, electrical stimulation, sometimes with laser, sometimes with ultrasound. You may use all those means for preparation. But the actual skilled intervention by the physical therapist to the patient, it takes about 10 to 15 minutes of applying the myofascial trigger point therapy techniques. And therefore, if we have to define that the time of the skilled intervention, it does not exceed 10 to 15 minutes on the patient. Then when you have the patient to do, or before you do the myofascial trigger point therapy, when you have the patient to do a hot pack, an electrical stimulation, or even an ultrasound, they don't require the same skill. They are not similar skillful interventions as the myofascial trigger point therapy is that a licensed therapist or a licensed assistant has to apply. And for that reason, myofascial trigger point therapy is extremely effective and extremely efficient, and I hope that in the near future we will be able to produce some evidence-based studies that will demonstrate the precise effectiveness and efficiency of myofascial trigger point therapy. Now, many of you know that when a patient has a trigger point, that trigger point may be activated with microtrauma, with a small in magnitude trauma. You don't have to have a huge car accident. You don't have to have, don't have to sustain a fall. You don't have to be hit by somebody or something. You can have a plain, small, repetitive motion because you are working in a supermarket and you are scanning objects over the scanner and you are overusing your hand and your wrist, or you are playing, let's say, baseball or basketball and you are using repetitively your shoulder. You are working in an assembly line and you are rotating your trunk and you are overusing your quadratus lumborum, or you are working as a car driver, a taxi driver, and you are continuously having your legs into hip flexion and you are overusing your iliopsoas muscles. Therefore, we don't have to have a huge trauma, but a small trauma, a micro trauma, can be enough to produce, to activate a myofascial trigger point. Then you're going to get pain, a burning sensation, and tenderness on the muscle that is involved. But also referred pain. As I explained to you, a myofascial trigger point refers pain to distal parts of the body. It's not only the specific area that the trigger point exists, but it will refer pain to distal parts of the body. But we may have also autonomic and proprioceptive disturbances. You may have a positive pilomotor reflex. In other words, the patient may develop goosebumps the moment that you try to apply the myofascial trigger point therapy, or dizziness, or lack of balance, or tinnitus, noise in the ear, as I mentioned a few minutes ago. We may have edema and cellulite, decreased blood circulation and accumulation of metabolic waste, and also we may end up having sleep disturbances. People don't sleep right. They can't sleep well. So this is exactly what I was talking about. The myofascial trigger points on the sternocleidomastoid refer pain in all these distal parts of the body, further away from the area of the problem. And obviously, we may have a taut band, a nodule, a painful nodule to palpation, what we call a patient pain recognition sign, a local twitch response, limited range of motion, and muscle weakness. And I will talk about that in a moment. But I wanted to show you here something that many of you may not have paid enough attention to. The question is, what is the right way to palpate a trigger point, especially when it comes to a superficial muscle? What is the right way to palpate it? Are you going to start palpating all over the muscle? Or there is a precise way, especially when talking about superficial muscles, to palpate a specific trigger point? Okay, actually, there is a precise way to palpate especially superficial myofascial trigger points. What is that way? You first palpate the muscle fibers across the muscle. So you're going to go actually along the muscle. So you go along the, actually I will take it back. I will start that from the beginning. Initially you have to palpate perpendicular to the muscle fibers. The reason that you want to palpate perpendicular to the muscle fibers is to identify an area that feels like a piece of string, an area that feels like a chord, like a guitar chord, an area that feels like a piece of rope. That's why you palpate perpendicular to the direction of the muscle fibers. Once you find the area that feels like a chord, once you find the area that feels like a piece of string or like a rope, then and only then you start palpating along this piece of rope until you find an area of nodularity, until you find an area that feels like a thick or thin nodule. And that would be the area of the myofascial trigger point. So when you palpate for a myofascial trigger point, you don't go all over the muscle. There's a very systematic approach to properly palpate the myofascial trigger points on that muscle. Then another important point is, what is the right way to apply trigger point therapy? And I would like to answer that question by going to the Hands-On Seminars website and showing you actually an article from the research section of our website. Those of you who visit frequently our website, in our website, if you go under research, you will be able to actually see different research articles that we have published, and you will be able to actually even view and print those articles. So one of the articles that we will discuss today is this article right here that discusses, it's called Reduction of Spontaneous Electrical Activity and Pain Perception of Trigger Points in the Upper Trapezius Muscle through Trigger Point Compression and Passive Stretching. This is a very interesting article, and I will explain to you why. There are many practitioners, many either physical therapists, or sometimes we deal with acupuncturists or massage therapists. Anyway, there are many practitioners who believe that they can take a trigger point and they can actually just compress the point, provide ischemic compression. And they believe that the compression of the point will produce adequate results for the resolution of the patient's problem. At the same time, there are practitioners who believe that if they take a patient and they just stretch them, that the trigger point is going to disappear. Well, both compression and passive stretching are important components of myofascial trigger point therapy. But are they effective if they are applied in isolation, or they are more effective if they are applied in combination? And I'm making a smiley face here as I'm drawing. So this is a study that we published at the Journal of Musculoskeletal Pain. And in this study, we took 3 groups of patients. The first group, we applied only ischemic compression. The second group, we applied passive stretching only. And on the third group, we combined passive stretching and ischemic compression. At the end of the study, we found that the group that received the combination treatment, the group that were received both ischemic compression and passive stretching, was the most effective group, was superior, statistically superior to the other groups in terms of reducing pain perception and also reducing spontaneous electrical activity. What we mean with spontaneous electrical activity is that we can take an electromyography needle and we can stick that needle in the area of a trigger point, and we see an abnormal activity called spontaneous electrical activity, which is significantly abnormal if the patient has a myofascial trigger point. When we properly treat that myofascial trigger point with a combination of ischemic compression and myofascial stretching, in a few treatments, we are able to produce this waveform that shows the elimination of this spontaneous electrical activity. And that is one of the positive effects of myofascial trigger point therapy. So the right way to apply myofascial trigger point therapy is not only via the application of ischemic compression, not only via the application of myofascial stretching, but combining the proper myofascial trigger point therapy with the proper stretching so that you can have the most effective results. Now, I also wanted to discuss with you specific pitfalls, mistakes that therapists do when they apply myofascial trigger point therapy. And I will start actually with the middle point that I have on this slide in terms of the accuracy of the point. So it's very important that you treat the myofascial trigger point therapy in the accurate spot. And how do you do that? I just described to you the specific way that you can palpate a myofascial trigger point, especially in a superficial muscle. You have first to go perpendicular to the muscle. You have to find the area that feels like a piece of rope. We call that a taut band. And then you move your fingers along that taut band until you find the nodule, the area of nodularity, and that will be your myofascial trigger point that you have to treat. That is the accurate point to treat. Obviously, you want to treat points that will produce referred pain, that will produce patient pain recognition, points that are truly affected with the myofascial syndrome, and not any point in the muscle. And obviously, looking at both at our video on myofascial trigger point therapy as well as our book, you can identify the most common location of those points. But the other point we have to make is choosing the correct muscle. Now, my friends, let me just go back and show you this. Let's suppose that this patient went to see a therapist and complained to the therapist that, I feel pain in the front of my head, and I feel pain in around my eye, and pain in the back of my head, and so on and so forth. Now, this patient complains of no pain whatsoever in their sternocleidomastoid muscle. Now, a therapist who is not properly trained, they may start treating the head. They may start treating maybe the temporalis muscle. They may start treating the frontalis muscle. They may start treating muscles of the head because they do not know that it is the sternocleidomastoid muscle that produces this referred pain. So when a patient comes to you, they're not going to come with little X's that demonstrate what muscle has the problem. So you have to know what is the proper muscle system to treat, and thinking that the only way to treat the correct muscle system is by knowing the referred pain patterns, it is also wrong, because you have many myofascial trigger points that the referred pain pattern overlaps with each other. You can have a patient with back pain. Now I'm asking you, the patient just complains of back pain. Do you know how many muscles, if they have trigger points, refer pain in the back. You have the quadratus lumborum, you have the lumbar paraspinals, you have the iliopsoas muscle, you have the gluteal muscles, and several other muscles that even part of the abdominal muscle can refer pain into the lumbar spine. So you have many muscles that can refer pain into the lumbar spine. So how are you going to select the proper muscle? So it comes to, yes, on the one hand, to knowing the referred pain pattern on the muscles, but on the other hand, it comes to asking the patient the right questions, taking the proper history. And this is something that we teach you in our seminars, how to take the proper history from the patients so that the therapist is able to determine the correct myofascial trigger point to treat and not any myofascial trigger point. And then we come to the final point, perpetuating factors. What are perpetuating factors? Perpetuating factors are factors that prohibit the patient from proper recovery. How many of you have had a case scenario where you treat the patient gets better, the patient goes home and comes back and the patient feels worse? You treat them, they get better, they go home, they get worse. You treat them, they get better, they go home, they get worse. How many of you have had that scenario? I'm sure over and over again it has happened to you to see this type of patients. So why does this happen? This happens because most likely there is a specific factor involved. We're going to call that a perpetuating factor that you are not familiar with that perpetuates the patient's problem. Let's suppose that you are treating a patient with a scalenus problem or a sternocleidomastoid problem, and the patient goes home, and after you treated them and they felt really good, they go home, they lie down on the sofa, and they try to watch TV with 54 pillows under their neck, or they're trying to read a book with 5 pillows under their neck. What's going to happen? They are going to overshorten the sternocleidomastoid muscle because of the improper head posture, and the problem will be perpetuating. The problem will be continuing. So it is extremely important that we're cognizant of those perpetuating factors for every muscle that we deal with so that we can be able to properly advise the patients about what the proper way is to live their lives. You can make or break a proper treatment by being cognizant about the perpetuating factors of patients and being able to provide them with proper information so that patients do not continue having these problems. In our seminars, we give a particular emphasis to these perpetuating factors, and we teach you what are the do's and do not do's, what are the good things and the bad things that the patient can do to in their daily lives to avoid perpetuating their condition. And I have here, for the accuracy of the myofascial trigger points, the most common type of palpation, which would be the flat palpation as it applies to a myofascial trigger point. And what I would like to do at this point, instead of going over further pathophysiology and so on and so forth, who many of you have either attend or many of you will attend and learn when you take our seminars, I would like to ask you, if you have any questions, you can go ahead right now and type your question, or if not, I will open up the microphones in just a second. But if you do have a question, please go ahead and type your questions in the box that is provided on the right-hand side of your screen, and the question will come to me, and I will be able to answer to your questions. I will unmute for a second.
Unmuted.
And I will ask that anyone has any question. Any question? Okay. Well, if I do not see any questions coming within the next few seconds, I will close the meeting for today, and I will invite you all in our next meeting on proprioceptive training. We will make sure that the next meeting on proprioceptive training will be opened up in a different way, so that everybody can have access, because as far as I understand, I have at least another 10 people who are trying to get in, and they're not able to get into the meeting. So we'll make that unlimited. But tell your friends that we'll send everybody an email with a recording of today's meeting, so they'll be able to get the recording. Ines, and I'm not sure, I hope that Ines is the Ines that I know from Brazil, who I am looking forward to see here very soon. Let me see, Ines, if I can open up your microphone. Hold on, let me see. Ines, can you hear me? Ines, can you hear me? Okay, I will then say what Ines's question was. Ines asked the question, how many sessions are necessary to make the patient feel better? Because that will connect to the effectiveness of the treatment. So usually we are seeing a good difference in the patient's symptoms within the first 2 to 3 sessions. Within the first 3 sessions, we see some difference in the patient's symptom. Careful though, it's very possible after the first or second session the patient to feel a little worse, because they may feel some soreness because of the way we apply the treatment. But the soreness does not mean that the patient doesn't feel better. The soreness is just an indication that you did some good work with your myofascial trigger point therapy, and that's why the patient feels the soreness. But about 3 sessions, we see a difference. Sylvia is asking the question, the shortening of the muscle will aggravate the pain? Sylvia, yes. Actually, over-shortening, and I will qualify that, repetitive over-shortening will make the muscle worse, because repetitive over-shortening will make additional muscle fibers to get stuck on the existing taut band. Ines is reporting to me that yes, she is talking to us. She is emailing to me from Brazil, and both myself and Mr. Rizopoulos will be delighted to meet Ines and the rest of the people from Brazil this coming October, when we visit the country, and we will be speaking also where guest speakers in the national conference will be delighted to do that. Let me see. One more question from another participant is, if myofascial trigger points are useful for fibromyalgia, the answer is a big yes. myofascial trigger points are good for fibromyalgia? The answer is yes. Now, let me qualify that. Fibromyalgia is a systemic problem. Fibromyalgia affects, if not all, most muscles, skeletal muscles that is, of the body. And therefore, the big question is, how do you choose which muscle you're going to start with? Can you do trigger point therapy in one session in the entire body? No, you cannot. And therefore, the question that you ask yourself is the following. What would be the specific treatment that if I apply it right now, it will make the greatest difference in that patient's life? Maybe that patient feels pain and fatigue throughout their entire body, but mostly they tell you that at night they wake up 5 times every night because they feel back pain. Well, this is the area you are going to attack first. You're going to attack first the back area because the quality of the life of the patient depends on having some quality sleep. Therefore, that would be the area that you have to apply first. If we have some research that supports that myofascial trigger point therapy helps fibromyalgia, there is some recent research out there was published, I'm sorry, at the Journal of Musculoskeletal Pain. I cannot quote it to you right now. I will type right now my email address for everybody to have, and I want you to send me, Brett, an email where you can ask me to quote for you specifically the research, and I will do that. I will provide you with that information. It will be my pleasure to provide you with that information. But let me go right here also and put my email address for those of you who want to get in touch with me. Let me see. There you go. That's the email address, dimi@handsonpt.org. All right, Brett, very good. All right, my friends, I will close at this point. I thank you very much, all of you, for participating. Again, we will disseminate a recording for those of you who were not able to attend this course. But pretty much once a month or twice a month, we will have these free webinars with different topics every time. Our next webinar in September, it will be on proprioceptive training, which is an amazing topic. And then in October, we will be discussing strain counter-strain, which is also a very unique type of treatment. So I thank you all for attending today's free webinar. And for more information, you can get in touch with us at handsonseminars.com, or you can email me directly at dimi@handsonpt.org. On behalf of Hands-On Seminars, I would like to wish to all of you good evening.